You've learned these in lab, right? And we're going to learn them again, and then we're going to add the function, of course, to them. And I'll give you a acronym. I think the acronym was on the video lecture as well, for each of the nerves. All right, so it is OOO, to touch and feel a giraffe's velvety auburn hair. Okay, I didn't think of this, but it would be hard to think of anything better. Okay, so OOO, to touch and feel a giraffe's velvety auburn hair. Okay, and you kind of have to bend a couple of these based on how you learned what the nerve was. So the first one is optic, and the second is olfactory. Oop, I messed that up already, huh? Olfactory, then optic, then oculomotor, then trochlear, trigeminal, oop, I don't need a dot there, abducens, facial, and then auditory, which is actually, what's the name of the auditory nerve? Right. Vestibulocochlear. Can
we write it on the test as either one?
Well, we're learning it as vestibulocochlear, but if you want to, auditory fits better in this acronym. Then we have glossopharyngeal, and what happens in this nerve stays in this nerve. Vagus. The accessory or spinal accessory and hypoglossal. All right, if you know these functions, so I already filled these in for you. Most of these, of course, make sense. Your olfactory is your smell, your optic is your vision. You have three that are for eye movement: the oculomotor, trochlear, and abducens. The trigeminal innervates the face for touch, pain, pressure, temperature. That's what TPPT stands for. We talked about that before. Touch, pain, pressure, temperature. And then also for chewing. You have three that are for taste: the facial, glossopharyngeal, and vagus. They also have different motor functions, so facial movements, saliva, and autonomic nervous system. The auditory, you know, the vestibulocochlear is for hearing, and the semicircular canals also attached to that nerve, which are for your balance, your equilibrium. The accessory is for head movement and swallowing, and the hypoglossal is for tongue movement and swallowing. So a lot of these make sense. A few of them you're going to have to associate somehow. All right, so whether they are sensory or motor or both, sensory and motor, there's another acronym for this. Okay, so this is, some say merry money, but my brother says big brains matter more. Okay. So B is for both sensory and motor. S for sensory and for motor. So some say marry money, but my brother says big brains matter more. And of course, this is going to go right in line with its function. This has both a sensory and motor function. So does this one, so does this one, so does this one. So what divisions of the nervous system are motor and sensory? So sensory is coming in. What does that mean? Or what's the term for that? Afferent, right? Motor is going out. Efferent. And because they are cranial nerves, they go directly into the brain. They do not synapse at the spinal cord. Right? Yes?
So are these the ones that form the, I forget what the word is.
Plexuses?
Yes.
No.
No.
They do not form plexuses. So those are the ones coming off the spinal cord.
What did you say that the TPPT standing for the trachea?
Touch, pain, pressure, temperature. Yeah. Yes?
What do the arrows going across mean on the ones that you...
So these are the ones with both. All right, so they have both a sensory and a motor function.
Okay, gotcha. What is
TPPT is touch, pain, pressure, temperature. All right, so you got these down? Okay, you also need to know the Roman numerals. So I don't know why it's Roman numerals instead of regular numbers, but that's what we're going to use, okay? You got to learn your Roman numerals, okay? Guess you can Google how to do Roman numerals if you don't know how. But it's not too hard. All right, so you guys got these down? Okay, I want to see if you can do it on the brain then. So if you go to the worksheet. Okay, so last time we did the spinal cord and the dorsal and ventral horns. As soon as you get outside of the spinal cord, you're then getting into the peripheral nervous system. So we're going to go through the anatomy of the different parts of the peripheral nervous system. So the nerves leading into and out of the spinal cord. We already covered the ones that go in and out directly to the brain. So what happens is you have this coalescence of nerves which comes together and they form, right before they get into the spinal cord, rootlets. Okay, just little branches that then lead into the spinal cord. And we're going to use the same terminology as we did with the spinal cord. We have our dorsal and ventral root. And the same direction of the pathways applies as well. So dorsal was afferent or efferent? Afferent, right? So we've got a bunch of nerves going towards the spinal cord, and the ventral root is efferent, going away. You have this bulbous matter in the dorsal root. Oops. The dorsal root ganglia. I guess it's only one, so it's a ganglion. And the ventral root doesn't have one.
So that's how you can tell them apart?
Yeah, also their direction. Or their orientation. So they come together at one point, and we'll call this the the spinal nerve. But they also split into different branches. So on the dorsal side, we have, I have to cross here. The meningeal branch, so that goes right into the meningeal layers and provides sensory information for the meninges of the spinal cord. And then we have our dorsal branch and ventral branch. Well, the ventral branch splits again, so some of it goes off into, organs, the viscera, but you also have these two smaller branches. And we'll get into more about what they do or how the signal goes through them. These are called the rami. Communicantes, or the communicating rami. All right, let's actually, not call these branches. We're going to call this a ramus, which is just a branch, but our more medical terminology. And so rami is plural. Yes, what?
Same thing for the meningeal branch? Or?
No, leave the meningeal branch. Well, I guess, yeah, you can call it ramus too. You can say both. Actually, I'm not sure if it's the meningeal branch of the dorsal ramus, but we'll just, whatever. Okay, so we have these two branches off the ventral ramus, and then you have this big ganglion here, which is called, it's part of the sympathetic nervous system. The sympathetic trunk ganglion, or it's also called the chain ganglion. And this connects to another one above it, so that's why I have these two branches coming off of that. There's a bunch of these all together, which go up and down the thoracic part of the peripheral nervous system. And that's where the sympathetic nervous system is going to synapse before it then goes out to the ventral ramus. But we'll get more into how that works when we talk about the sympathetic and parasympathetic nervous system. Yes?
So is the chain part supposed to be chain trunk or chain sympathetic trunk?
It's, let's actually just delete. The chain ganglion. Okay, it's part of the sympathetic pathway. Or the sympathetic trunk chain ganglion. Ganglia, multiple of them. And so this is going to go, and we only drew it on one side, but this, of course, is going to go on the other side as well, with the same bilateral symmetry. Yeah?
So you talked about previously that meningitis was caused by steroid injections into the spine. Does that have anything to do with the meningeal rami?
I'm not sure. So you can get, when that happened, that outbreak a few years ago, there was some sort of bacteria or fungus on the needles that they were using, so they were using contaminated needles. And it was injections of cortisol that they were injecting into that area. So I don't think it had anything to do with the ramus because they were actually injecting things directly into the meninges. But that would be where the pain would be associated with. It would be associated with information going through the meningeal ramus up into the spinal cord and the nervous system. Okay, so that's the basic anatomy of the peripheral nervous system right next to the spinal cord. When we get into, again, the sympathetic and parasympathetic nervous system, we'll talk more about how these synapses further downstream into the viscera. Okay, we do have 4 plexuses. I'll say plexuses, yeah. Plexi, I don't think it is plexi, I think it's plexuses. And these are associated with different parts of your spine. And depending on which textbook you use, there is some differentiation whether this nerve is part of this plexus or the other. There is some overlap in these plexuses. So we'll just stick to what your textbook says. But the first one is the cervical plexus. Which goes from C1 to C5. Okay, and the big nerve in there is the phrenic nerve, which goes all the way down to your diaphragm and controls your breathing. So if you have a cervical vertebral injury and you affect the phrenic nerve, then you can no longer control your own breathing. Okay, we then have the brachial plexus, which goes from C6 to the first thoracic vertebrae. Maybe remember one of those tests from that video where he was pushing on, I think it was the pinky, right? He was pushing back. That first thoracic vertebrae went all the way to, that first thoracic nerve went all the way to that finger. And there's a number of nerves. One of them is the median nerve, which we've talked about before when we talked about carpal tunnel syndrome. All right, so the median nerve travels within your carpus underneath this transverse ligament and then goes up into your hand. So when you get carpal tunnel, that's the nerve that is inflamed and then causes pain in your hand or numbness or tingling. Okay. All right, then we have the lumbar plexus. And the sacral plexus. So these are named after the vertebrae which they go through, so it should be really easy to remember them. All right, the sacral plexus has the largest nerve in your body, the sciatic nerve, and this is definitely one which I'm sure you've heard of because it's associated with most people that have like lower leg, lower back pain. Sciatic nerve passes through some very integral parts of your back, so when you have back injuries, it will often get inflamed. And we covered a couple in the lumbar, right? The obturator nerve and the femoral nerve. Put those on there too. These are also large nerves that will also get inflamed with back injuries. All right, and the fifth on here, we have thoracic. But the thoracic do not form a plexus. Okay? but they are, you know, everything from T2 to T12 have their own separate nerves, which then innervate all the way to the skin. And as they innervate the skin, they all fall in a very specific pattern that everyone has, which form these what are called dermatomes. Okay, and I have a fun story about dermatomes. So I went camping a few years ago, and a week or so after I got these bumps on my stomach, and I thought it was poison ivy or poison oak. And it itched really, really bad. But then after a week, it started to like hurt. Like it hurt, the bumps and stuff hurt. Especially when I was sleeping, like it was really uncomfortable. And so I still just was trying to ignore it. Another week went by, and then it hurt really bad. And it started spreading, but it started spreading in a line across my belly into my back. Anyone know what that was? It wasn't poison ivy. It was shingles. Okay, which is a nervous system disorder, and they generally infect across the dermatome. So that's why it was in a line across my body, because it was going up the dermatome. But then as soon as I figured out it was shingles, like the next day it started to go away. So you can survive shingles, or I did. I'm a survivor. But dermatomes are also used because they follow these specific nerves, as part of the neurological exam. So, you know, they might feel this inner part of your leg. Can you feel that? Can you feel that? What they're doing is they're targeting different nerves to try and see where the injury is or where the condition is, which affects it. So that's something you could use for your discussion. Yes, Jason?
Yeah, I had a similar thing happen on my mission where I had something, it was like a mild form of shingles, but it was called herpes zoster.
Yeah.
And it was like right under my neck. And we looked it up, and it was like basically a later manifestation of chickenpox.
Mm-hmm.
As a result of that.
Yeah, so I was just having this conversation yesterday with my neighbors. So who's had chickenpox here? I had chickenpox, okay, a few people. Most people have not had chickenpox because you have a chickenpox vaccine. But it is the same virus which causes shingles. And what essentially happens is the virus is still in your system somewhere. It's just not active. And in periods of stress or sickness, you will then, it will come out. And that's what shingles is. Interesting side note about shingles is it is associated with Alzheimer's. So this is just something I read recently, one of the preventative measures you can take for Alzheimer's is to get the shingles vaccine, which isn't normally distributed, but it is available. So I also had a student in Oregon who got shingles on her face. And there is medicine that you can take for it that helps it recover faster. But like with me, she didn't, and the doctors, they didn't diagnose what it was until it was like really painful and had kind of taken over her face. But it went away eventually after she started taking the medicines. Yes?
So the shingles vaccine, if you've already had chickenpox, is that going to do anything?
Yes, because it's like an extra boost, essentially, to prevent shingles from reappearing. Like, I've had chickenpox, had shingles. Just because you've had the chickenpox vaccine, you can still get shingles.
So that shingles vaccine, does that last forever after you get it?
No, and I think there's booster shots for it as well. And it's not even 100% guaranteed, but it is the next level of preventative measure for it. That's all I've got for